John Bennett, broadcasting from Miami. Today we have a hangout with Richard Mendel, spinal neurosurgeon from Tampa, Florida, an excellent teacher. He's going to talk to us about stereotactic surgery and other neurosurgical topics. And the host, I'll turn it over now to the host, Simon Downs of Japan. Welcome, Simon.
Thank you very much. My name is Simon Downs. I'm coming to you from Japan for InternetMedicine.com, and I'd like to start by introducing everyone, have everyone introduce themselves. So let's start with Dr. Ben. Would you like to introduce yourself, Dr. Mulpuri? And I think you're muted at the moment.
Oh, yeah, just unmute, Ben.
Okay, sure, sorry about it.
There you go.
Yep. Hi, folks. I'm Dr. Ben Mulpuri from Michigan. I'm an internal medicine physician, and I'm also executive MBA graduate. I'm very much interested in this digital medicine, and I'm very much excited to join this hangout today and to learn more about this spinal surgery.
Thank you very much.
Yep.
Thank you very much. So I suppose we should ask everyone to mute our mics,
Okay.
and then we will listen to Dr. Mendel make his presentation.
Okay. All right. How's the audio now?
That sounds great.
Okay. Well, last week we spoke about stereotactics and stereotactic surgery. And so really, last week there was a paucity of video or any kind of photo media. So I think it was probably pretty hard to visualize stereotactic surgery. So, I did mention last week that stereotaxis now is applied to all types of surgery, including general surgery. The orthopods do stereotactic hips now. But in neurosurgery, cranial neurosurgery was really the first time that stereotaxis was applied to humans, was neurosurgically on the cranium because of the nature of the skull and the fact that you could fixate the stereotactic frame to the skull. So although Dr. Victor Horsley and his engineer and physiologist, Dr. Clark, invented their original frame, which was the Horsley-Clark frame at the University of London in 1905. It took them till 1908 to start using the frame and getting it as accurate as it needed to be. But it really wasn't until Spiegel and Weisses in 1952 first applied stereotactic frames to humans, to human subjects. So Ernest Spiegel, he was a neurosurgeon at Temple University in Philadelphia, and Henry Weisses was the neurologist who assisted Spiegel. Weisses was reported to be a very brilliant guy, and so the start in humans was in Philadelphia at Temple University, and the Spiegel and Weiss, the frame that Spiegel and Weisses uses now somewhere on display, but I don't know if it's still at the university. Let me advance this a minute. Okay. All right, so last week when I spoke to you about frames and frame placement, this upper left-hand corner, this happens to be a Lex El Frame. So this is made by the company Electa. And so the Lex El Frame is really a very widely used frame. That would be a commercial name, and again, no vested interest in Electa or any of the frame companies. This is the Lex El Frame, and as you see in front, the two posts, which you can see right here, they go up kind of high to capture the frontal bone, and the two posts in back, depending on where you're going to be, whether you're in the posterior fossa or up higher near the pineal region, that's what's going to determine the height of the posterior pins. Now, this is a model here. Again, this happens to be the Lex El Frame of the frame once the arc is put on. Once the arc is put on in the OR, then you're really ready to drill and biopsy and pass the Nash hold or whatever biopsy needle you need to the X, Y, and Z point that you've localized. So this is a typical appearance of a patient who in the morning is, or whatever time of day, but usually early morning, getting the frame placed. Because with the frame placed, they're going to need an MRI or perhaps a CT to show the target as best as possible in relation to the fiducial markers that the frame is able to provide. And like I said, that becomes very exact once you're down to your three coordinates. All right, so this is what the frame provides. Now, this image here is when you slide a radiolucent plate onto the frame on each side. It will give you your Z coordinate, but this is more illustrative, really, of a different frame, which is the old BRW, which is now called the CRW frame. That's the current iteration of it, and that is made by Radionics, and that would also be a commercial name or brand name. So with the frame in place, you have your different planes organized into X and Y, just like you would on a plane graph, a two-dimensional graph. Your Z coordinate, of course, provides you the depth. So again, here's an image of the frame on the skull prior to putting on the arc. Okay, now we did mention Victor Horsley earlier, and Dr. Lars Lex El is pictured here. This is Dr. Lex El in the 50s, maybe even the 60s, and this is his Lex El apparatus or frame apparatus that he designed. But he also designed the Gamma knife, and conceptually this is what it looked like years ago. It's gone from being the standard Gamma knife, which was like, I believe, 201 separate beams of a linear accelerator, which was cobalt based. Now the newest model, which is the Lex El Perfection, I think is 192 different linacs. But the fact is that's not all that important. But you're getting, multifocal beam of a linear accelerator from so many different source points. The nice thing about that is that it's very easy on the patient in terms of dosing, and usually is done in one sitting. With other linacs, like, and this is neither an endorsement of one over the other at all. Dr. Adler's CyberKnife really is a tremendous delivery system in that it moves into all different frames as it doses with the linear accelerator, but it moves around the patient It's very interesting to watch. Now, again, here's the frame. These bars here are probably the most uncomfortable portion of the entire procedure when you place it, because these bars need to be placed in the external auditory meatus rather snugly so that it fixates the frame while you're applying the pins, and that can be a little painful. That just requires some Marcaine or lidocaine injection into the skin, and then the 4 different pins are placed. But this is a little bit uncomfortable. I'd probably say this is the most uncomfortable part of the procedure. But with a little midazolam and being talked through it, the patients tolerate it really very well. So from the frame, this is what you get with your intraoperative imaging once it's superimposed onto the MRI after the frame has been placed. And so I'm sorry, I'm moving a little bit. The indications really for stereotactic surgery are several. One is for multiple brain mets. Stereotactic surgery is ideal. The other is for stereotactic radiosurgery, where you're going to be delivering a dosage of radiation to the brain. And this then is what you mentioned last week. Do you actually need a needle or a knife? And the answer is no. If you're not trying to biopsy anything, if you already know your tumor type and histology, the radiosurgery can be done without really any physical penetration of the skull other than applying the pins, the fixation pins, which is very superficial. But this is more for multiple mets. If you're trying to biopsy the mets, you're going to drill a very small twist drill hole to allow a needle biopsy and core sampling of these mets. But if you're just trying to treat the mets, not with radiation, there's really nothing more invasive than the fixation pins to the skull. There are alternatives also. In terms of the fixation pins, again, this is Dr. Lex El and the original concept of the gamma knife. Well, I think that I had a few more slides for you, but one of the options, instead of using a frame, is to use a mesh, a plastic mesh that really adheres to the patient's face. And from what I understand now, and I mentioned last week, I think that's also being used for stereotactic breast biopsies. They're using a mesh to fixate the breast so there's not much motion. And in talking to a colleague who does some stereotactic breast biopsies, apparently also they use a technique where instead of confining the breast to a small space and passing a needle into it, they're actually letting the breast hang with gravity to better visualize the lesions and do the biopsy. But again, I have no experience with that. I was just trying to answer some questions that I think it was Wendy had mentioned last week about it appeared a lot more inexact than with the cranium. But as I said, you know, the brain, just like the breast, is a lot of mostly fat and just lacking in neurons. But what allows for the precise nature of the stereotactic biopsy is really that Monroe-Kelly doctrine we mentioned. That is the fact that the only things, contents of the skull are brain, CSF, and blood. And so that's what allows you to utilize three-dimensional space with the skull. Essentially, the other slides were just mechanisms for fixating the skull, other than with pin fixation. So really more non-invasive. It's really fairly precise, but I don't think you're getting the sub-millimeter accuracy that you do with a stereotactic frame. I think in terms of stereotaxis, then, we could talk more about different types of stereotaxis in more specific instances, but stereotaxy really is the first thing that allowed more in the way of exactness in terms of location and elegance in biopsying. And remember that this is over a century old now. So this came way before, well, not way before X-ray, but way before notions of pneumoencephalography and injecting air or contrast into the spinal canal or neural axis to make exact markings. And it came the invention of the frame was in 1905 to 8. CT wasn't really in wide use until the mid-70s, late 70s. So, this came way, way before radiographic advances. And so now, stereotaxy, in terms of a frame, is used, it's part of the neurosurgeon's toolkit for exactness, but very few intracranial procedures today are done without some type of stereotaxis or image guidance whose principles all depend on stereotaxy, except in trauma. In trauma, you're often doing less precise work, but it's often more emergent. So I think in terms of the basics of stereotaxy, that really about covers things. Now, we could talk more about localization principles and all that, but as far as stereotaxy, that's really about it. So I told you I thought it would be pretty short this week.
Oh, that's okay. Richard, I just have a question. Now, how, not knowing anything about stereotactic surgery, how widespread use is it used in the field of neurosurgery? Just academic centers or every neurosurgery
I
center?
think, I think it's used internationally, worldwide. Now, academic centers are going to be using it more often because in private practice, you're often not doing as much cranial surgery as you would like, but the principles of stereotaxy are known to every neurosurgeon, and I'm sure many orthopods are adopting it now for stereotactic hips. And then Eli Ori from Mazor Robotics in Israel has designed a really great robotic system for spinal surgery that I think is really fantastic. Now, I have no interest in Mazor Robotics or any of the other groups that are making very good progress with spine stereotaxy. But the spine is so mobile that it presented a lot more difficulty in the geometry of how to fixate the patient and avoid movement at a specific area. But the idea that you're going to be able to use principles of stereotaxy and localization with things like scoliosis is really incredible.
Yeah, as a matter of course, Richard, are neurosurgical residents all trained in stereotactic surgery?
Oh yeah, yeah,
Oh, okay.
yeah, yeah,
Okay.
yeah. It's
Part of the curriculum.
yeah, it's definitely part of the curriculum, and it, I guess in some ways it becomes less exciting nowadays because stereotaxy is incorporated into everything, but the precision with which you do a deep, deep brain stimulation and everything else is dependent on stereotaxy.
Okay.
Movement disorders, all those things are very, very dependent on stereotactic principles.
May I ask a question?
Sure, sure.
Before your presentation, I was looking on YouTube for examples of stereotactic neurosurgery, and I was looking at a video on dystonia and chorea, and they were using fixation pins, and when the frame was attached, the area where the fixation pins were entered just blew up like a balloon, and it looked very invasive. I was wondering what would you like to see as far as improvements in the procedure, or do you think we're already there?
Well, actually, I think probably what you saw, I can understand it looked horrible, but that actually, what we do is when we put the frame on, the patient should be somewhat sedated with a little midazolam or some type of, usually a short-acting benzodiazepine. But what you do is when you place those instruments, the Electa, for instance, in the Electa frame, when you're placing the positioning device into the external auditory meatus, you don't want to put too much pressure there, and you want to have your assistants really holding the frame and helping stabilize it. Now, the radionics frame, it has a Velcro strap that helps you, which is fine too, but the point of the thing is that you want to have two assistants there holding the frame and stabilizing it, and then as you line up the four posts with the skull and where the pin is going to ultimately be placed, what you do is you inject lidocaine, Marcaine or lidocaine, usually with some epi, to prevent any bleeding, but with some epi into the skin, and you blow up. There's a lot of swelling under the skin, but that swelling is really just what's called a wheal, W-H-E-A-L, a wheal of the skin for the anesthetic to work. That actually works beautifully. I mean, the patients don't complain about that, but I could see where if you just saw that thing and you thought they probably should have shown you the injection itself, because it's not as gruesome as it seems. A lot of people say that the frame wasn't the worst part. They would say they were just anxious, and I think it was Reese Cosgrove or one of the MGH neurosurgeons had the residents place a frame on him so that he could show the patients that he had gone through it and he knew what he was talking about. Because I think what was happening was he was explaining, it's not that bad, it's not too bad, don't worry, it doesn't hurt. And then I think one of the patients said, have you ever had it done? And that prompted him to go get it done.
I see. And regarding before the operation and the neurological exam, I've looked at, just as a student, looking at how they test the cranial nerves and the basic exam. What type of neurologic exam was needed before that?
Well, I think that based on the fact that you and Eleonora and Wendy are still in your medical school training, I think we should talk about the neuro exam and maybe that's what should be the next talk. This is a commercial product, and I am recommending it and have no financial interest in it. But there was an app put out by the University of California, San Francisco, on the neurologic exam, and it's a disc with. Let me put the slides away, okay? It's a what do I hit, the blue button now, or can you see me?
You can hit the screen share button again, or you can stop sharing. There you go.
All right. There's it's available on the. I know it was on the iTunes store, but it's an excellent app, very interactive on the neurological exam. Now, I would encourage you to look at that, because I can tell you that there are good older pre-MRI era neurology textbooks just on the exam that are hundreds and hundreds of pages.
I see, really.
And I think what you really need to understand with the exam is not memorizing the steps of the exam, but really understanding what parts of the brain or nervous system you're testing and where they localize to, because that's what allows you to be much more efficient in what you order. Because a lot of people outside the world of neurology, neurosurgery, psychiatry, they often order things that are often very low yield. It's not a criticism. I'm sure I inadvertently order things that may be of a lot lower yield than I understand, but for things like degenerative problems in the spine, it is incredibly unusual to find operative lesions in the thoracic spine. The thoracic spine is often a site of trauma, but because of the ribs and the way the spine's fixated and the way that there's such a lack of movement in the thoracic spine, not very common to see, degenerative disease in the thoracic area. So, that's usually not something I use in screening somebody that has complaints referable to a common level like 6'7", 5'6", lumbar, or lumbar spine where there's so much motion. I tend to reserve thoracic spine for the findings that are like a crisp sensory level on the thoracic spine, but things are very defensive here, so you do have to probably order a more thoracic spine series than you need. But I'm very picky about the thoracic spine when it comes to trauma, and neoplasms, but certainly less so when you're getting a story that's consistent with a degenerative disease problem.
And do you sometimes have medical students that are training with you, or rotating through, and then you have a chance to take them through that?
Yeah, I like to have them, but I don't have them that often. In private practice, you don't get nearly as much exposure to residents and medical students as you like, but I still try to get someone involved.
I see.
Okay, you got us, Richard. Richard, I really like, I've mentioned this before, Sidman and Sidman. One thing that helped me learn is the tracks in neurosurgery.
Yeah, I think that's a good point, John. Sidman and Sidman was great. There was Sidman and Sidman. I think there was a Gilman and Gilman too, wasn't there?
Yeah, that was a pharmacology book, yeah.
Yeah. That was Goodman and Gilman.
Goodman and Gilman, yes.
Yeah, pharmacology.
But I think there was another neuro one that was Gilman and Gilman, I think. Well, it doesn't matter. But you're right. Those tracks were important. But remember today, today everything's changed because of all the tractography that's being done with MRI. We're
Okay.
learning more about tracts than we knew. So what you learned, you know, like going up the cuneus, the gracilis cuneus, and the gracilis, the fasciculus cuneatus, the fasciculus gracilis, like the carried sensation up the posterior tracts, and then gave you motor output. Those are still really important. But now we're learning tractography of all these exotic areas of the brain that we never knew before. So I think you're right. I think what I'll try to do in the next talk is we'll go through some of the tracks, because Simon and Wendy and Eleonora can, you know, get exposed to them, but we got to build on all those tracks, and some of them aren't really even known yet. It's functional MRI that's defining them. There is another really good software program that I will tell you about next time, and it's something. It's like the Atlas of the Brain in 1,689 parts or something. But it's great because you can see the fiber tracks and play with them now, when, you know, we just didn't know the tracks very well, other than the basic tracks you mentioned from Sidman and Sidman. I think that might be pretty interesting. Right?
Yeah, it is very interesting. I was just thinking, you know, I was talking with Dr. Mulpuri today. We had a short hangout, and I was asking him about what's it like to run a code, and I was asking about the different drugs you've given. And just spending a few minutes talking with him, I learned so much. And in the same way, listening to your presentation, I go away from it just with a head full of knowledge that I wouldn't have gotten from a book or answering MCQs. And I wonder what it is psychologically that makes us remember situations like this.
Well, you have to. The way to remember is to, you know, you got to build on the principles that get taught to you, and very rarely do the specific details of things in biochemistry matter as much as the big picture. You really don't want to be a reductionist. You don't want to start focused down on your highest power. You want to start global and go granular. So when you're talking about a code situation, I know I empathize with you, because in medical school, in the third year, we had this anesthesiologist, this great anesthesiologist named Rance Stone. We used to call him Tom Stone. He's now passed away, but he knew physiology inside and out. And, you know, when we were in physiology and in the cardiac lectures, we learned a lot of detail that really didn't hang together very well. And then when you learn how to code somebody, you have to fall back on what are the basics, the ABCs, right? And from the ABCs, you can think through what you need to do just on the building blocks of reestablishing flow and the ABCs. ABCs are everything. So, and if you haven't heard it yet, the ABCs are for airway, breathing, and circulation. But then when you do trauma, you'll do ATLS, Advanced Trauma Life Support, and then again, it's the ABCs. Airway, breathing, circulation, you know, you always have to go back to the basics. And you're not thinking in terms of the Krebs cycle. You're thinking in terms of oxygenating the blood and then getting the blood where it needs to be. And you're more concerned with things like volume and compression, it's just a much more gross way to think about it. And the recommendations for your pressor meds change every few years, but it's not a big change. It's whether the epi goes in this dose or this dose, or you just have to step back and think about, you know, you don't want to be one of the 6 guys looking at the elephant, the blind men look at the elephant. You want to be the person look at the whole elephant, not just a part of it. So when you have somebody who you're trying to resuscitate and it's trauma, you're worried most about too little volume, not too much volume. So you usually are trying to, fluid resuscitate the patient. You don't think about the hard things. It's the it's the simple things. You're probably in some ways outsmarting yourself when you're trying to recall all these details of the lecture. Just hit the high points at first.
I see Dr. Malpari nodding on that. Do you have a comment regarding that? In your running
I mean, basics are basics. Like he mentioned, those medications, dosages, and those things might change. The order or the way that, as we learn more. I mean, as we get more experienced and as we, get more evidence through over a period of time, things might change. But the basic ABCs are the same forever. Airway, breathing, and circulation. So that's basically what it is.
If you got no airway, there's no point in doing anything else. You've got to get an airway first. If they're not breathing, don't bother doing anything else till till they're breathing. So, just try to focus your attention on the important issues. I mean, the energy consumption of the pentose phosphate shunt. It does become important in the ICU, but the critical care guys will explain that to you, and you'll understand it. Don't be worrying about that. When you're
I memorized it one time and I forgot it.
But that is something to think about when you have a failing liver and you're trying to maximize energy, but it's not something to think about in a code situation.
And also, we say this. I'm sorry to interrupt you. I mean, look at the patient, not the clinical, the micro things like the labs and stuff. Look at the patient, how he's doing as gross patient.
Right. That's really, that will carry the day 95% of the time. 90% of the time, you're in a hospital where lots of smart people are around you. And all you have to really do is figure out which patients are sick and which patients aren't. Then you know who to go to. If you can do that, you're ahead of the game. Just identify the sick ones, and it's like that. I told you, it's what Dr. Zilka told me at Queen Square. When he found out I was a surgeon, it was appalling to him. But he said, "Oh, don't worry. Medicine's been the ruin of many a good farmhand." He talked to me like I was an illiterate. But, there's somebody smart enough to help you if you can just figure out who needs care and who not to touch. Another neurosurgeon told me about Alan. Alan called it how-tos and who-tos. You can see lots of great operations described in books, but they rarely tell you who to do it to. You've got to figure that out. So the who-tos are a big part. How-tos are fine, but the who-tos are where the wisdom is.
How-tos and who-tos. Okay.
Yeah. So let's try to review some basic tracks next week and employ a little of the physical exam, and then with the physical exam in the future, when I show you cases, I'll try to be more concise about what was on the exam and what we were looking for. And remember that the three portions of the brainstem, your midbrain, pons, and medulla. Okay, because there's 12 cranial nerves. 4 of them are in the midbrain and above, 4 of them are in the pons and above, and 4 of them are in the medulla and above. So you can organize it pretty nicely.
Wow.
You have a good idea of where in the brainstem you need to look.
Wow.
the anatomy of the brainstem itself is so complicated that I'll actually give you a reference next week to the micro anatomy of the brainstem. It appeared in the Journal of Neurosurgery a few years back, and it's incredibly confusing. But it was very well done in picture form, but you know, you'll at least know how to localize a lesion to the appropriate level in the brainstem. All right.
Well, thank you. I'm looking forward to that.
All right.
Okay. Dr. Bennett, do you have anything to add?
Oh, yes. Yeah, thank you very much, Richard. Now, one quick question has nothing to do with what we're talking about. Are you a big fan of mnemonics in neurosurgery?
Mnemonics?
Yeah.
Oh, there's mnemonics in everything. Yeah.
Yeah, I love them. I love them.
Yeah. But I was going to tell you one Henry Schenken story since you mentioned.
Oh, yeah, I love that guy.
Can you? All right. This will be edited out, right?
Yeah, sure.
Okay.
Well, let me finish the show, then we'll talk.
All right.
Okay. Thank you very much, Richard Mendel, and
Okay.
thank you, Simon, for hosting.
Thank you. My pleasure.
Thank you, Ben, for coming from Michigan.
Thank you. Thank
See
you,
you
Dr.
next week.